Good afternoon, everyone. This is Janice Tondora. Thanks for joining. I'm going to be your facilitator for today, and I'll start with introductions in just a minute. But we did have many more people registered. So just with it being after lunch, Vanessa, is it okay if I give it just a minute or two before I dive in?
Yeah, absolutely. Go ahead.
Okay, great. So thanks for being here, and please be patient with us. We'll get going in just a minute. All right, everyone. I am thinking, just in the interest of being respectful of your time and you all joining me on time, we are expecting many more people. We may or may not get them. We can be a small and mighty group today. I'll say a little bit more about myself and introductions in a minute here. And we're going to have lots of opportunity to talk this afternoon about our topic, person-centered recovery planning. Just a couple of logistics before we get started. You do have the ability to unmute your phone lines. I would ask that you keep them muted if you're not speaking, but this will be very interactive, and I will sort of prompt for feedback and questions at different points in time. So please feel free to do that. I'm going to reserve time at the end for questions, but you will learn quickly I'm pretty informal in my style as a presenter. And again, I sort of welcome you asking questions as we go throughout. I may tell you, hold that thought, we're going to get there in a couple of slides, and or we will address it at the end, but please feel free to put questions into the chat and or unmute if you have a burning question you need to ask. I want to acknowledge Vanessa. is it Ronsky? Am I pronouncing that correctly, Vanessa?
Great.
Okay. Vanessa is from one of our partners, C4 Innovations, and she has graciously asked to help me, agreed to help me out with some of the logistics and is going to help me monitor the chat and with some of the breakout rooms I have planned. We will be taking about a 10-minute break about midway through to let people stretch, take care of any emergencies, etc. And I would just ask, in sort of the spirit of interactivity, I would encourage each of you, if you are comfortable when you can, to have your cameras on. It does help me to kind of gauge where you're at, or if people have questions, you can also feel free to flag me down. That's helpful. And we'll be doing some breakout work as well, and it's helpful for partners to see you in that breakout work. We'll be using the chat box pretty frequently for some interactivity and exercises, so be ready to use that, both to offer us some input and some feedback. And at different key points in the presentation today, Vanessa's gonna help us by dropping in some documents that you will need to be accessing in order to participate in the exercises. So consistent with the description, I'm going to do some coaching and some teaching around person-centered recovery planning, but we're going to have an opportunity to actually apply that to a hypothetical story of someone that we call Roma, who is living with some significant mental health and substance use concerns, as well as some primary medical issues. And you're going to have those documents that Vanessa drops into the chat so that you can get familiar with Roma's story. So again, just be on the lookout for that when we get to that point. And last but not least, I would say, if you have not participated in MHTTC webinars in the past, usually within a couple of weeks, this webinar is being recorded. So the materials and the webinar archived recording will be available on the MHTTC website. And certainly feel free to point folks in our direction. So Vanessa, let me know, did I miss anything by way of logistics? Feel free to interrupt me as I kind of go through here a little bit more with the introduction. And also again, Vanessa, feel free to point out things to me in the chat. And again, you all are welcome to unmute and point something out as well for me if I miss it. I'm pretty good about monitoring things, but I'm juggling a lot. So who am I and what am I doing here? So my name is Janice Tondora. I am a clinical psychologist by training. I am based at a program called the Program for Recovery and Community Health, which is a Department of Psychiatry program in New Haven, Connecticut. I have a background in disability advocacy as a whole because I have a family member with a traumatic brain injury. And person-centered recovery planning is a topic that is near and dear to my heart. I do a lot of work in Connecticut and around the country, really on the translation of recovery-oriented principles into recovery-oriented practices, and have a particular interest in what that looks like in the practice of collaborative recovery planning. And over time, people have come to refer to me as kind of the nuts and bolts recovery lady, which I always kind of laughed at. But I am hoping that what that means is that I really am in a position to sort of offer you some sort of concrete tools, guidance, et cetera. Because in my experience, this practice that we're going to talk about today, it oftentimes fits with the values that we carry into our work in the field. However, the recovery movement has sometimes been light on kind of practice guidelines about what should we do more of, less of, differently. What do you want us to be thinking about and doing when we sit down to co-create a plan in partnership with someone? So that's a bit about what we are going to cover today. In particular, the hat that I am wearing in today's webinar, I am currently the PI and co-director of the New England Mental Health Technology Transfer Center. If you are not familiar with the MHTTC initiatives, we are one of 10 regional centers around the country dedicated to the support of workforce development and the dissemination of evidence-based practices. We are joined by two of our specialty centers, the Hispanic Latino Center and also the American Indian and Alaskan Native centers. And all of those centers are kind of woven together with the support of our network coordinating office. And they're really woven together in a really vibrant and rich sort of tapestry of resources collectively across all the centers. So if you are not familiar with our work, it is very diverse and rich across the centers. And I would just encourage you to kind of check out the various websites because they're really a wealth of material and resources. Just by way of introduction, a little bit more detail about our particular MHTTC. We are covering Region 1, the New England region. Our primary partners are C4 Innovations, where Vanessa is affiliated, along with the Harvard Department of Psychiatry. We do collaborate very closely with other regional centers, the Addiction Technology Transfer Center, the Prevention Centers, our SAMHSA Regional Administrator's Office. But most importantly, we are really dedicated to inclusivity within the New England MHTTC, which means that we have a very vibrant advisory board and a network of stakeholders, people actually receiving services, people actually doing the work, and people who are involved in administration. And so we really work hard to make sure that what we offer is informed by what you all say that you need. And also kind of the input that we get from the field. So that's just a little bit about our particular MHTTC. Each of those MHTTCs has a particular niche or a content area of focus. Our niche here in New England happens to be around recovery-oriented care and systems transformation. And what you're looking at up here is our set of guiding principles that were developed in year 1 of this initiative in partnership with our stakeholders. And they really guide all that we do. And what I love about the topic we're going to be addressing today, person-centered recovery planning, is that I think you will see that this PCRP practice really does embody all of these principles in concrete practices in action. So again, we're really going to try to focus as much as possible on kind of the nuts and bolts and what this looks like and have an opportunity to practice together. But before I go any further, I always like early on to start with an acknowledgement, which I think is really important, which is that I think that trainings on recovery-oriented care or person-centered care, they can come across as very critical, and people who are participating can sometimes walk away feeling really invalidated, right? As if they're being sort of criticized and everything that they're doing is wrong in their work. And I really want to, start and recognize and say that that is not my intent in today's webinar. We're going to talk a lot about what it means to be strengths-based with the people that we support. But I think a lot about parallel process. So I try to take that approach as a teacher myself. And I know that there is beautiful person-centered work happening in the field, and I want to acknowledge that. But I also know that for a variety of reasons, we sometimes have a difficult time translating some of these things into practice. So there is room for improvement, and hopefully you see today as just kind of an opportunity to get exposed to some new tools and resources and kind of take your game to a next level, okay? So let me pause there before we go a little bit deeper and just see, do we have any questions in particular about kind of general approach, what we're going to be covering today? Everybody's okay with logistics? I don't see anything in the chat. Vanessa's dropping some links. Thank you. So we're good to go, it looks like. Okay. Okay, so just a little bit by way of background in terms of where this practice of PCRP comes from. I would really describe this in many ways as being what I call and refer to as sort of the perfect storm, right? So first you think about it as being kind of a values-driven approach, right? Acknowledging that it's just the right thing to do. And for many years, when I had these conversations out in the field, I would often refer to the golden rule, right? So think about if you or a loved one is presenting at a behavioral health treatment facility or center, how would you want to be treated? And so I used to encourage people to use that as a guide. And then just a couple of months ago, I was doing one of these webinars and a participant, raised their hand and said, well, Janice, the golden rule is dated. It's got to go. We have to be talking about the platinum rule. And I said, well, tell me what's the platinum rule? And I really loved it, right? And the platinum rule is not treat others how you want to be treated. It's take the time to know how they specifically, as an individual, how do they want to be treated, right? And then adjust our own practices to meet them in that space, which I think is really critical because it gives us an opportunity to really accommodate individual preferences, cultural preferences, because we're going to talk about a lot of things today, including things like shared decision-making, and in general, people wanting more of a say in the treatment and in the decisions that impact their lives. But having said that, we have a tremendous amount of variability across individuals. So I love the platinum rule. That's my new favorite. So certainly it's a values-driven approach. State health and social service agencies around the country are increasingly requiring person-centered planning. We've got federal and national endorsement dating all the way back to the Freedom Commission, from Substance Abuse Mental Health Services Administration. We have a whole national center called the National Center for Advancing Person-Centered Practices and Systems. That's what NCAP stands for. If you're not familiar with the work of NCAPs, they do really amazing work, and their website is among the best I have ever seen for resources. So just Google NCAPs. And increasingly funders, Centers for Medicare and Medicaid Services, Joint Commission, accreditation agencies, CARF has had standards around person-centered planning for, I think, probably couple decades at least now. We've got research data, if you're a data person, that shows we get better outcomes when we deliver more person-centered planning and partnership with people. But most importantly, in this storm, kind of advocating for person-centered planning is the voice of service recipients, right? When I have a voice in my own plan, I really feel a responsibility to work it in my recovery. And we hear a lot of that in the field, actually talking to people with lived experience, that there's been a number of improvements, especially over the last decade or so, to really engage in authentic partnerships with people. But despite that, we sometimes feel like people don't quite have an equal voice and that things drift from what is most important to them. So this practice is really an opportunity to change that and kind of keep moving in the right direction here. So that's just a little bit about the background. So it's really, it's been an evolution over time, especially for those of you who have been in the field for a long time. I know myself as a clinical psychologist, I think I had very solid training, yet at the same time, I was very much sort of trained in a narrow sort of clinical model of what's the problem, how do you come up with a multi-axial diagnosis, how do you tag the treatment plan to that? And I did not get as much support in sort of what is my role as a psychologist in thinking about the whole person and what would that actually look like in a collaborative recovery planning process. So one thing that I want to point out about this slide here is that you'll notice it's an arrow flowing from left to right. That was very intentional in the graphic design because this is not sort of a rigid sense of us saying that everything on the left-hand side has to go, and now we're doing everything on the right. There are still aspects within our traditional methods of treatment planning that continue to be critically important, including the professional wisdom that you may bring to the table in the partnership as practitioners. But what we're trying to do within this model is really figure out how do we blend that with the wisdom of lived experience in more of a kind of a shared decision-making model. So I won't go through all of these, but you can see some of the shifts that, we're really talking about here. Just, I mentioned shared decision making. If you're anything like me, I'm living with a range of pretty serious medical issues. And so I see a lot of doctors, and even in all my specialty care, I've seen a lot of evidence in recent years of more shared decision making, getting copies of my notes, having access to my medical records, having actual input when I sit in the waiting room to tell my doctor what my priority is for today's session. Those are all a reflection of some of this evolution and moving toward a more person or patient-centered model in care. And we'll be talking about how roles change in the process of meetings, how the team gets expanded to include beyond the traditional cast of characters, right? So traditionally, we often think about, a primary clinician, maybe a psychiatrist, we might have a substance use counselor, and those people continue to have valuable input, of course, but we're also trying to use the moment of planning to help build a person's natural recovery support network. So whether that is friends, family, someone from a faith or a cultural community, could be a neighbor. I've seen neighbors be involved. We're looking to expand the team to really kind of flesh it out and use that as a moment of opportunity. So I think that you will see how each of these play out as we go further this afternoon and talk about what some of the key practices look like. But I want to stop talking now and get you all talking with me and with each other. So we're going to do just kind of an opening exercise, because what I've mentioned so far is just a little bit of an introduction to the model, a little bit behind the perfect storm of forces that's pushing for it. And when we're kind of talking at that overarching level, what I often hear in the field is that, well, don't we already do all of this, Janice? And while there are many aspects of this that I think are alive and well, there are also things that are not universally or consistently implemented. So I like to illustrate that with just a little opening exercise here that I've been doing for years. So I'm going to ask you, how many participants are we up to? We only have 14 folks. Let me use the chat box for this one. So first question I want to ask you to put into the chat is, first of all, take off your recovery hats, take off your person-centered hats for a minute. I'm going to give you permission to do that for this part. And I want you to think about traditional treatment planning and traditional treatment systems. Think about, how do we traditionally define improvement for people who are living with serious diagnoses of either mental illness or addictions issues? What do we traditionally value as markers of improvement? What traditional outcomes get measured? And go ahead and just put some of those ideas in the chat box. Here, I'll get us going. Medication compliance, compliance of all shapes and sizes. Yeah, abstinence, managing symptoms, less symptoms, achieve and maintain clinical stability. Yep, sometimes we're looking at, improving sleep, staying out of the hospital, right, JC, right. Where else do we want people to stay out of? We don't want them to go to the hospital. Where else don't we want them to go? Jail, yep, exactly. More coping skills. I saw the word cooperation, sometimes gets linked up with what's referred to as compliance, managing crises, kind of from day to day, mental flexibility, less ER usage. Good, Marianne. How about, I don't know if any of you are in rehabilitation type of roles like community support, but there's a 3-letter acronym that we historically focus a lot on in behavioral health services. Anyone have any? Yes, ADLs, good, Cassandra. Activities of daily living, better hygiene. Are you taking care of your apartment? Are you paying your bills? Okay, so a lot of focus on ADLs. How about the way someone thinks about their illness or their addiction? Historically, think about the experience of mental health concerns, mental illness. Historically, we want people to have improved what? Begins with an I. Anyone have any ideas when they think about their illness? Yeah, independence more so in recent years, Cassandra. Insight, right? We think, right, a lot traditionally about you want to have improved insight and recognize and acknowledge the fact that you have been given a diagnosis of schizophrenia or what have you. In the addictions arena, we've talked about kind of the parallel concept of denial, okay? So I just want you to keep those things in mind right now. And now I'm going to give you your second part of the exercise, which is first going to involve you writing something down on a piece of paper. And after you've done that, I'm going to ask Vanessa to put us in breakout groups in pairs, okay? So that's your cue, Vanessa, to get ready while I give them their instructions. So what I want you to write down on any scrap piece of paper, 1, 2, 3. Forget your professional work right now or your role. I want you to think about yourself as a human being, okay? And I want you to spontaneously write down the 3 things that give your life meaning, the most important things to you in your life. What gets you out of bed in the morning? What keeps you happy? What gives you a sense of purpose? 3 important things to you in your life that give your life meaning. Okay, so I'm going to give you just a minute to do that. And then Vanessa, are you with me to get them into breakout groups here in a minute?
Yep, it's all set.
Okay, I'll let you know when. Okay, so here are going to be your instructions, and we're going to give you, I don't know, maybe 4 minutes, a couple of minutes each. When you get into your breakout room in your pair, I want each of you to tell the other, I'm taking number 2 off your list. I'm crossing it out. Just pick randomly, you know, whatever it might be, cross something off the list, okay? And then once you've had something crossed off your list by your partner, I just want you to have a brief conversation about what would your life feel like if that thing were taken away from you or out of your reach, okay? So take your list of 3 things. Vanessa's going to jet you off into your pairs. Partner crosses one off and have a conversation about what that would be like. Everybody with me on the instructions? All right, Vanessa, why don't you go ahead? Thanks, Amy.
I don't know what's wrong with my camera. I guess.
All right. It looks like we have everyone back. Okay, so let me, first question that I would just like to hear, you can unmute your phone lines. I'll try to kind of look around and call on you or raise your hand here. Anybody willing to just first share on your own list of top 3 as human beings? Just talk to me a little bit about some of the things that were on those lists. Anyone want to volunteer?
I'll volunteer.
Sure, go ahead, Denisha.
Number 1 was my son and family. Number 2 was my health. And number 3 was mental stability.
Yep, great, excellent. Thanks for getting us going. How about other people?
I'll go. So mine was my faith, family, and friends.
Yep. I hear those 3 F's a lot: faith, family, friends, right? And sometimes in the family, we even get furry family. I hear animals and pets sometimes come in with this. Yeah. What else? Another volunteer?
Sure, I'll go.
Sure. Go ahead, Valerie.
Mine were relationships or connections,
Yep.
Independence, and health.
Connections, independence, and health. Right. Good, good, good. All right. Anybody else want to share before I pop something up here on the screen?
I don't mind sharing.
Sure. Yeah, go
I
ahead.
had family, friends, and work.
Yeah, family, friends, and work, right? Sense of purpose and even practical reasons work, right? Okay. So here's what I want you to observe on the screen up here, okay? So when I first asked you to think about in traditional treatment systems, like what do we value as outcomes for people receiving services? What do we look for as traditional markers of improvement? You see that there's a lot of focus in this list, looks like the list on the left, right? But then when I asked you to tell me a little bit about your top 3 as a human being, we got a list that looked much more like the list on the right. And I just want to get a couple of comments. What do you notice about these 2 lists? Are they the same? Are they different? How do you feel about them? What do you notice?
Well,
Go ahead,
This is
Amy, and then we'll
me.
come back to you, Valerie.
Okay.
well, obviously, I mean, the ones on the left feel sort of depersonalized. They don't feel warm.
Yeah.
They're obviously clinical in some respects, clinical language, or saying realistic expectations seems very limiting, or that's my, it's more fun on the right.
Yeah,
Nice
I love
nature, music, pets,
it. Right. The left side, it's not very warm and fuzzy, is it? The right side is a lot more fun. There's a lot of things that speak to our hearts on the right. Valerie, you wanted to add.
Yeah, I think I agreed with what Amy said, and I don't know, that just seems like the right-hand side is more like human,
Yes.
human experiences, as opposed to, yeah, the more sort of clinical reflection on the
Yeah.
left-hand side.
That stuff on the left really kind of speaks to us. It resonates, right? Let me go back, Amy, something that you had said, how like the left-hand side is very kind of clinical, which often comes up, and there is truth to that. But I also always like to sort of make the statement early on that while that's true, in the person-centered world, clinical is not all bad, right? We don't want to use clinical terms to capture the entirety of a human being, right? And we don't want the quote unquote clinical stuff or the problems to crowd out all those things on the right. But please know that this is a model that's based on partnership, right? And this is not a model that is anti-treatment or anti-clinical. It's about thinking about our work in a different way, okay? Any other reactions people observe about these? How about if you woke up every day for the rest of your life and the best thing that you had to look forward to was that stuff on the left? How would you feel? JC, you're smiling.
Yeah, that would be torture.
Yeah, it'd be torture. I don't know if I'd get out of bed, right? Okay. All right. So hopefully you see already where I'm going with this, right? So when we think about traditional treatment systems and what we value as outcomes for them, right? List looks very much like the list on the left. But when we think about our own quality of life and what gives our lives meaning as human beings, we get that list that looks more like the list on the right, okay? So there's like this us-them dynamic, right? And this model of person-centered recovery planning is an opportunity to really figure out how good quality clinical care, recovery-oriented clinical care can actually support and be in the spirit of those things that are most important to people, okay, in their lives. Amy, you have your hand up.
Yeah, if this isn't a good time for this question, that's fine. I really appreciate what you are saying about that this is collaborative between clinical and person-centered. Part of the reason I appreciate it is because I no longer do clinical work. I'm an educator in higher education, and I am educating and training people to do clinical work, specifically in addiction treatment. And I've been struggling a lot over the last few years with sort of my experience with the recovery community, and I'm using recovery here right now very specifically for addiction. So
Yeah.
the rise in like recovery coaching as a credential,
Yep.
all of that, I've found it to be very unfriendly, very divisive. That's been my experience in terms of the clinical side of the house, if I can use that binary,
Yep.
let's say. And so I don't know if this is something, you're with the Mental Health Technology Transfer Center. I don't know if the Addiction Technology Transfer Center or people that within that are, you know, the peer or recovery model. I don't see that as being collaborative right now.
Yeah. No, I appreciate you bringing that up, and we can have hopefully an opportunity at the end to come back to some of these things in more detail. First of all, I will tell you that at least from a training perspective, trying to really embrace and get this stuff out. I actually just did a abbreviated version of this webinar. Some of you may have been on it for the Addiction Technology Treatment Center's New England Summer School. But I think what you are talking about is a reflection of change, right? Like when we have these kinds of changes, inevitably they involve tensions and people really kind of struggling to figure out roles and how do I get my voice at the table in a meaningful way. I have seen those tensions evolve around the country. I've also seen developmentally with time that they get better and people get to a place of mutual earned respect. So what I will just say is I'm glad you have the opportunity to collaborate with recovery coaches and give it time. I think, you know, again, the tension is necessary to get to a place where this, I think, is a true partnership. If people have felt excluded or marginalized, then they carry anger into the process and the partnerships for a bit. But over time, we earn each other's faith is what I would say, and trust. Right. Good observation. Let me ask another question of the group. Couple of volunteers, what got crossed off your list? And tell me what your life would be like if that thing were taken away. Who's willing to volunteer?
I mean, I'm happy to volunteer, although I just feel like I spoke and I don't want to
That's okay. We'll mix it
I
up.
don't want to overstep the mark here in terms of
Okay.
allocation of time. So
Oh,
my list overall was like a little bit different than other people's. Maybe it was more specific. I don't know. So my list was reading, thinking, and my husband. That was my list.
Yep.
And then I was with Valerie and she took off number 2. So that was thinking.
Yeah.
I was bumping up against thinking as obviously I would have the capacity to live my life, but just that I wouldn't be able to do the kind of like deeper thinking or spend time doing that
yeah.
in my
Okay.
life. And that would be really hard for me.
Yeah. Yeah.
There
Okay.
could be a way in which it's better because I
No,
can
no,
torture myself,
No,
but
I
it would,
think, yeah.
it would
Go
be,
ahead.
I would not be happy.
Yeah, you would not be happy. Okay, so think about this for a minute. I think that example is actually very relevant, right? When we think about treatment, one treatment we often offer is medications. And sometimes we offer medications to help with thinking. But if you talk to people receiving services, there are also medications that make quiet voices, but people can't think straight. And some of those things that you just described that are so important to you and thinking and visioning, right, get compromised, right? So that is an experience I think people have. Elizabeth, you want to jump in? Unmute.
Faith got crossed off of my list. And so I think that I would spend a lot of time searching for that, you know, again. So it also is in some ways, you know, there when you're having a hard time and it's there when you're okay. But when you're having a hard time, it becomes really important as a place of comfort at times. So
it takes away your rock, like your foundation, right? So again, to use Elizabeth's example, this was a number of years ago, and I hope it's not still happening, but I have seen in inpatient facilities where a person's Bible has been taken away from them because they are perceived by professionals to have religiously oriented delusions, if you will. So again, I have seen that happen in some ways. Cassandra.
Mine was actually work that got crossed And while that might be a great thing to kind of like not have to do that, but at the same time, it would be like a domino effect of like no longer being able to support my family, not like lack of financial security, lack of purpose.
Right. Okay, so I'm so glad you brought up that domino effect. Okay. So again, Cassandra's job got crossed off, right? Think about a person who enters a treatment planning meeting and they say to a professional, more than anything, I want to be able to work and be a good provider for my family. And the message they get in return is, we know that's important to you. And when you've done 90 meetings in 90 days and you've been quote unquote clean, then I will refer you to supported employment. But not until then. So essentially, that person's experience is that their job and their livelihood and ability to take care of their family gets crossed off their plan, and abstinence gets put on the plan with that kind of a narrow focus. Okay. So what I'm trying to illustrate here is that despite some of our best efforts, we do still have people that say, for a variety of reasons, and I will be very transparent here, I don't believe anyone on this call or the people that I work with every day go into this business to cross anything off of a person's list. I think we go into this with good hearts, wanting to try to help people live good lives, right? But for a whole variety of reasons, people do sometimes feel like somebody in the room other than them has the power to decide what two things end up on the plan and what gets delayed or crossed off. Okay, even I do a lot of work in residential settings, for example, and I have heard people say, before I die, I just want my own nest. I want a key to my own apartment. I don't want to live in the state hospital. I don't want to live in the group home. And I've seen the response. Again, we know that's important to you. We'll get there. And when you're med compliant for 6 months, then we'll initiate the referral to the supported apartment. So medication compliance goes on the plan, and that sense of like building a home of one's own gets crossed off. Okay. So this model is an opportunity to change that. Okay. And so I think it's really important to start in this emotional space of recognizing what it can feel like when you don't have maximum control over these really critical decisions that impact your care and your life. Because at the end of the day, people who live with mental health concerns or addiction, they want the same things out of life as everyone else, right? They want to thrive. They don't just want to survive, okay? And this method of collaborative planning is an effort to move toward a model that supports that, okay? So let me illustrate this also with an example. Again, sometimes we operate under the assumption that we already do this. I think examples sometimes suggest otherwise, and I like to concretize this early on before we go into some more key practices in the documentation. Again, we'll have an opportunity to practice a plan together. So this was a story that was brought to my attention by a center that I was doing some work with. And they kind of called me up and said, Janice, we're supporting this young man, and we think he has a lot of potential, but he won't get with the program. He's really angry. He's refusing to meet with the team, doesn't want to talk to the doctor. He's uncooperative, non-compliant. You know, you hear a lot of those terms, right? And they had said to me, can you help us figure out what to do with the recovery plan? I said, well, first of all, tell me the story, right, of this man's life. And so this was the snapshot that they gave to me, basically. So this was a young, married Puerto Rican father of 2 young boys. He was living with a diagnosis of bipolar disorder. And when he would get especially distressed by symptoms, he would tend to drink. He would use alcohol, which was leading to a bunch of kind of volatile arguments in the home with his wife. Okay. And at one point during those arguments, it got very heated and he put his hands on his wife, and she was shoved to the floor, and she fortunately was not seriously hurt, but that incident prompted a couple of things, okay? So there was a domestic disturbance call to the police, there was an on-site emergency kind of evaluation, there was an inpatient hospitalization, and then the most important consequence was that Mrs. Gonzalez said, you are not going to see me or the boys until you get it together, basically. And she still stayed very involved in his care, but she was setting some very clear limits. So he essentially lost his family, which was devastating for him, because he would tell you that his love for his family and his faith in God were the most important things in his life, okay? Not unlike some of you who wrote down your top 3 things, okay? So keep in mind how they described him: uncooperative, non-compliant, angry. Keep in mind this story. Then I said, send me a copy of the working recovery plan that you developed with Mr. Gonzalez. And this was basically what they sent me. Achieve and maintain clinical stability, stop your assaultiveness, comply with all of our rules and our groups, right? Leaving him in this really uncomfortable place. I'm here to give you back your goals because you stuck them on my recovery plan. And his goals in life were not to take his lithium, increase his insight, reduce his assaults, and comply with groups and meds and all that type of thing. Some of these things may ultimately be a useful part of his person-centered recovery plan, but in and of themselves, these are not his goals in life. This is not what speaks to him. This is not what's going to motivate him to dig in and do the hard work to achieve the goal that was really most important to him, which, what do you think it was? Who will unmute and tell me? What do you, should be pretty clear. Don't make Amy do it again. Someone jump in. But thank you, Amy, for being willing.
I think his family.
Yeah, right. Exactly, Mary. I want my family back, okay? So let's go a little deeper here. So if we can acknowledge that that is likely the way we want to organize plans to engage and motivate and follow people's leads, why is it that we struggle to do it? And what does this model look like, okay? So what you're looking at up here, I'm gonna go through a bunch of slides of key practices before we shift and we start practicing documentation. But what you can see up here, we often refer to these 4 keys of person-centered recovery planning, and they all have to come together in synergy to make this work, okay? Critically, at the bottom, you have to have the foundation of recovery, the philosophy. Believe that people can and do recover, they can and should make decisions about their lives and their treatment, okay? That kind of philosophy often leads to a different kind of a process, right? So facilitating conversations differently, planning meetings, the roles that we occupy, that the person occupies look a little different if we're really supporting them and kind of being in the driver's seat. Then, assuming we have a different kind of a more person-centered, partnership-based process in the green, that process should lead to a very different kind of recovery plan that concretely looks different. That's what you have in the gold, and we're going to practice. And then finally, all of those things to come together in support of really loftier aspirations. Like, what is the purpose of care? Yes, we want people to be able to stay out of the hospital and stay out of jail and stay off the streets. But more than anything, we want people to live a good life in the community based on their terms and how they define it. So we have different kinds of outcomes and purpose, okay? You will see, and these slides will be available to you. I try to embed a lot of links into my slides, and you see there's a nice example of one here on the bottom right when you get it. This is linked to a nice like 7.5-minute video on this 4 Ps model that we've gotten some good feedback on just for new employee orientation to get a conversation going in a staff meeting. So again, just pointing out that resource for you, okay? So let me talk a little bit about some of the process pieces here. So right out the top, we're talking about nothing about us without us, right? We want people to be a partner in the planning meetings and conversations. We have a peer specialist with our program, Kimberly Guy, and she says, like, we can't have these pop-up meetings, right? So she's often had the experience. She kind of shows up at a mental health center and kind of gets the message. Today's the day, your treatment plan is overdue. You have 17 minutes. What are your hopes, dreams, and desires? You know, ready, set, go. So it feels kind of sprung on a person in the moment. And if it's sprung on a person in a moment, they don't have time to be thoughtful about it, to kind of organize. So we want to be thinking about things like advance notice, talking to people about some reasonable control. When do you want the meeting to happen? Who do you want to have be there? And I know there are limits to this, and I want to emphasize the word reasonable. I often refer to my own experiences in healthcare, and I've had some very patient-centered experiences and many not so patient-centered. But typically speaking, when I call my doctors, what I will say to them is, listen, I will come in any day of the week, but if you can make the appointment for the end of the day, that's going to allow my husband to come with me. And he's a really important part of my decision-making. And I would say 99 times out of 100, that is honored. And I would suggest if we looked at those same statistics in behavioral health, that we still have a ways to go. So systems are doing creative things, again, like appointment cards, trying to work on scheduling, helping people invite others to be involved, whether it's by phone or in the room. Just the critical nature of if the plan itself that comes out of the conversation is a manifestation of the partnership, then what message does it send to the person if we are not taking a copy and putting it in their hands and saying, this is what I think I heard you saying last week when we talked, did we get it right? And if not, what do we need to change together, okay? And actually going over it with them. You know, hopefully what you will see by the time we're done today is that these kinds of plans are a meaningful and practical part of the work. They're not just bureaucratic paperwork for billing and compliance that gets stuck in the chart, never to be referred to again. They should be a meaningful part of your partnership and shape what you do together, okay? And then there is kind of a shift in structure or roles in planning meetings. And one way to shift some of those roles that people take in meetings, including the role that the person takes, is making sure that we're also educating people who receive services about what this is all about. So let me just say a couple of words about a few of these things. So even thinking about your meeting logistics, some of you, raise your hand if you work in teams, or some of you may just do one-to-one work, but do any of you work in teams? So Marianne, Cassandra, so you see this in residential settings, assertive community treatment, wraparound, all that kind of stuff, okay? And these things really apply to the one-on-one conversations too, but I think they're particularly important when you think about a group meeting where there might be a lot of people around the table or around the Zoom room these days, okay? Just making sure that there's introduction and that the person and any people they invite, family or loved ones, they know exactly who each person in the room is, and making sure that we give the person our undivided attention, which should seem like a given, but I will honestly say, and I have been guilty of this myself, these things here are right like a blessing and a curse, meaning that we never get away from our phones and our technology. And I've seen a team gathered around a person and they're getting text messages and they're having to respond to text messages. Sometimes they have computers open and they're catching up on documentation, okay? So if this really should be sacred space and protected time where the team is gathered around the person. And so just being cognizant of, you know, things like that. And things that make a big difference to the experience of the person in the room. And if you're sitting, I've had this happen many times, not as much recently, but if you're sitting in a room with a group and there's a primary facilitator, say the individual has said, you know, I want my clinician to help lead this meeting and facilitate it, right? And so the meeting conversation is happening and people are talking. I have seen things happen where the meeting leader or the facilitator turns to like the person who runs the rehabilitation group and says, oh, I noticed in the chart that Joe has not been going to the last, 4 weeks of, the rehab group. So what's going on with Joe? But meanwhile, Joe is right over here, right? And so just think about the experience that Joe would have, right? It's not that the group leader's input isn't important, but we have to be really conscious of that dynamic, and somebody has to be brave enough to step into the space and say, you absolutely want to get your input, but Joe, like, why don't we just start with you? Like, what's up? You used to love that group. Why aren't you going anymore? Is it not working for you? Do we need to do something differently? Right? And then inviting others into the conversation, because things like that and actual process make a huge difference in the person's ability to actually feel invited and to be a true partner, okay? The other thing that can help people feel more like a true partner is making sure that they know what to expect ahead of time, okay? So what you're looking at up here is just one example. This is very old now, but it's still very useful. We wrote this back in 2009, but it's a very simple toolkit. We have a version in English and in Spanish that are posted on the website listed there. Vanessa, if you're listening, can you do me a favor? I didn't double check the current link on that. Can you make sure it's still live for me?
Yeah.
We can get you another link. Yeah, get you another link if needed. Sorry about that. But basically, this was a toolkit that we were, sorry. Occasional interruptions does not typically happen. Sorry about that. So this is a toolkit that we developed with people in recovery, for people in recovery, all about person-centered planning. What is it and why should I care about it? How is it going to make a difference in my life? It's got some nice embedded user-friendly worksheets. What should I think about ahead of time? What are my priorities? How do I communicate those to my team? Who do I maybe want to invite that's supportive of me? And we have found that this makes a huge difference in the degree to which someone feels comfortable speaking up and discovering their voice once they enter into the conversation, okay? So when you think about person-centered planning, a lot of times the systems I work in, they provide a ton of training and support to practitioners, right? Clinicians, doctors, rehabilitation folks. But if this is really a model that's about partnership, you have to build capacity and confidence on both sides of the partnership equation. And things like this toolkit are a really important opportunity to do that. And for those of you, raise your hand if you are lucky enough to have peer specialists employed at your organization, people in recovery delivering. So Cassandra, Marianne, some people, JC, okay, good. For those of you that happen to have, either at your agency or through collaborations, have peer supporters, we have seen this be a beautiful combination where peer supporters can actually take toolkits like this and they can do mini trainings. They can host office hours. They can have people come on in and sit down and say, hey, your plan's coming up a couple of weeks from now. Let's walk through some of this together so that you're really feeling comfortable and ready going into that meeting so it meets your needs. So the places we have seen get the most traction with this model are the places that have really figured out how to just benefit from the talents of their peer supporters. It fits beautifully with that role of helping people sort of rediscover their voice and self-advocate. I think, was it Marianne? Someone had a hand up. I lost you in my Zoom screen. Can you help me? Was that you, Marianne? Did anyone?
No, I raised it just to acknowledge, but no questions.
Okay, okay, all right. So think about the power of your peer specialist there. It's just might be my kind of plug there. Okay. So a few more process tips. I referred to this briefly in the opening, right? That the team can look a little different, right? Historically, the team is often the typical cast of characters, a doctor, a clinician, what have you. But we're seeing more and more advantages to making sure when we have them available that peer supporters being involved, natural supporters, friends, family members, kind of expanding the circle, okay? If we have planning meetings for 20 years that are with a doctor and a clinician, and the person is looking to the doctor and the clinician, right, only, then we've missed a really critical opportunity to help them expand their natural support network. And the moment of planning is an opportunity to do that. Like, how might your husband contribute? How might your neighbor help you out with that goal? Okay. Talk a lot about self-determination conceptually. Practically, what that might translate into are things like the expansion of advanced crisis plans, whether or not you may be utilizing the advanced crisis planning portion of something like the Wellness Recovery Action Plan model. Each state has different policies, but there are legal rights around creating an advanced directive, right? Meaning that if it becomes necessary for me to use the hospital, including potentially involuntarily, do I have the opportunity? Where can I write down what is important to me, what works for me, what doesn't? Who do I want you to call? Those are really critical tools of self-determination because they allow people to hang on to as much autonomy and power in their decision-making when, due to the sake of emergency, it might temporarily be restricted. Okay, so that would be a concrete example of a practice that supports self-determination. Okay, and let me say a few words, elaborate on the bullets, the bottom 3 bullets there that I think are particularly critical. This could be a training unto itself. I referred to this in the opening. There is no fidelity scale for person-centered recovery planning, right? There are representative practices we encourage people to think about, but to say that there would be a fidelity scale would really go against the grain of what this model is all about, because it's really all about fiddling with the model to see what fits best for the person. And that is influenced by cultural preferences as well as individual preferences, okay? So in particular, I think it's important to acknowledge there's a lot of focus on shared decision-making, self-determination, person-centered recovery planning, because there are many people who articulate wanting more voice and power, right, in independent decision-making. But that is not a value that is embraced universally across cultures, nor is it embraced within all cultures. You know, there's a lot of diversity in individual preferences, okay? So it's important to acknowledge that. We've done a lot of work in our community with Latino individuals doing this kind of research. And it's not uncommon for someone that we're supporting to invite an elder, maybe an aunt who raised them. And that person may say, I'm really not comfortable making that decision. I really want my aunt to weigh in here, right? And I'm not going to say in that moment, well, this is the person-centered world and it's all about independent decision-making, so you really need to call the shots here, right? Because that would be disregarding an individual and potentially culturally influenced preference. So this is really just a caveat that it's not a one-size-fits-all reminder, especially as it relates to different cultural preferences are important to take in consideration, okay? Another thing that I think a lot of increasing attention, and rightfully so, which is we wrote this article for that NCAPS, the National Center for Person-Centered Practices, last year. And one thing we're having a very rich dialogue about is the relationship between person-centered care and freedom, right? Because if you think fundamentally, person-centered care is about helping people live a good life in the community, right? And have freedom to build a good life, freedom to realize their potential, freedom from oppression, freedom to make choices, okay? Especially the last few years have taught us that not all people are equally free, okay? So say you are co-creating a recovery plan with someone and they want to go back to work more than anything, okay? And we may have a good conversation collaboratively about ways we can help people overcome mental health symptoms or addictions to kind of get closer to that employment goal. And in the process of doing that, we also find out that they are experiencing overt discrimination in the community, either based on their gender identity, the color of their skin, their religion. We have to really acknowledge and address those different sociocultural influences that prevent people from living a good life in the community, right? Because unless we're also figuring out and acknowledging that, and potentially educating people about their rights, directing them to appropriate resources in the community, they're going to really be stuck and have a hard time getting traction. So it's just, again, trying to be conscious about the expanded things we have to kind of take a look at here, okay? I think this is my last slide on the, one more slide on processes. So community life and community inclusion, another concept that very often comes up in recovery planning. And everyone pretty much agrees that it's like mom and apple pie. Like, of course, community life is important. But again, sometimes in the kinds of treatments and planning that we offer, we can subtly and not so subtly undermine people's efforts to engage in their community. And this is like probably a 20-year-old example, but it's still one that taught me the most in my career. So I share it. And I went down to an organization, and I was meeting with a team, and they were having a very difficult time. They were trying to help this man named Jerry come up with some goals for his recovery plan. And he was really struggling to do that. And I forget who's in the room, a clinician, a case manager, a doctor, a substance abuse representative, maybe. I forget exactly, but I just interjected and I said, Jerry, just tell me a little bit about your like typical weekly routine. Like when you think about that, like where do you feel most at home and most alive, like most comfortable? And so this is what he shared with me in that meeting. He said, well, there's this little pub that I just love. I like to go there and I have a tonic and lime. I just chat with the patrons. Not sure what it is about that place, but it makes me feel good. Maybe it's a lot like Cheers, Janice. It's just a place where everybody knows my name. I'm just Jerry, period. I'm not Jerry, the mental patient, right? I can remember him saying these words. And now we're in a treatment planning meeting, working on goal setting. Think about the people around the table. And what do you want to guess was their immediate reaction? Amy's laughing because she knows. What do you think? Someone unmute. What happened? What do you think? You can put it in the chat if you're not uncomfortable. Mute in there. I'll say one word to summarize it: panic. Right? There was this immediate reaction of goal number 1 on the treatment plan. Thou shall induce high risk, avoid high risk substance, inducing environments. Okay. So immediately people's wheels start spinning and the questions start happening. But here's a couple of things I want you to know about Jerry's story that are contextually really, really critical. First of all, he had no history of substance use. And people actually believed he was having a tonic and lime. He actually really just wasn't a drinker. Okay. And quite frankly, if he wanted to sort of belly up to the bar and enjoy a cocktail with his neighbors, that is within his right to do that. Okay. Second thing, contextually very important, Jerry was, I don't know, a 50-something-year-old white Irish Catholic male living in a very heavily dominated Irish Catholic neighborhood. Okay. So I don't know if anybody's Irish Catholic, what is the center of the universe in an Irish Catholic neighborhood? Amy, what do you think? Sometimes it may be the church, but it's also the pub, right? Okay. So the pub, when you go and you sit with your neighbors and you chat with the bartender, sometimes it's a place where you get a job lead. You get a lead on a cheap apartment. You get somebody who says, hey, I want you to meet my sister. I think you guys should go out on a date, okay? Those things sound like beautiful person-centered recovery goals that could maybe help Jerry build a good life in the community, depending on what he wants, okay? And I often use this example because it's just a classic example of that slippery slope of jumping in too quickly and potentially discouraging something that was really critical to his life in the community, okay? All right, language, strengths-based language is a huge part of this. We often carry strengths-based values in our heart, but quite frankly, myself included, we have very bad habits with our language based on the way we're taught, just consistent language and shortcuts that are used in behavioral health treatment systems, okay? And again, myself included, I spent a lot of time working in inpatient facilities during graduate school. And I openly acknowledge that every referral or discharge I wrote for a long time started with the language, patient is a 53-year-old chronic schizophrenic with a long history of medication noncompliance leading to chronic institutionalization, okay? That's how I started. And it didn't get much better from there. And if that's the story and the kind of language that we use to tell the story of someone's life, it's almost impossible to back your way out of that into a good quality strengths-based person-centered plan. So we have work to do, myself included. Every time I do these trainings, a lot of times I'll get feedback like, what about this word, Janice? You could say this better. And so I'm constantly, again, trying to sort of be self-aware myself and come up with different terms. I just want you to look at one example in the language, because this becomes really relevant in the documentation, okay? Top note is a note that I pulled out of a chart years ago, modified just slightly. Just want you to take a second to read that. And then the bottom note is a note that I've tried to really transform through a more strengths-based, person-centered lens. And I just want you to take a look at that and then get a couple of thoughts about what you notice is different. So what do you think? Somebody unmute, what do you pick up on? What do you notice that's really different across these two narratives? You can put it in the chat also. Go ahead, Valerie.
I just noticed that in the top one, I mean, other than obviously referring to the patient sort of in the third person, is there's no demonstration of her own actions as being self-directed,
Right.
Participating in her care.
Yeah.
So, and you totally get that in the bottom one.
Yeah. She gets no credit in the top one, right? She's this passive recipient. When she does what she's told to do, she's stable. Whereas you get a sense of like her self-agency and her recovery in the bottom. Great pickup. Who else? What else do you notice? Amy, you want to go ahead? We're getting a little feedback on your line. I'm going to mute you, Amy. Sorry, I think we're having some technical difficulties. What else do you notice? Yeah, Stacy's picking up on that same distinction. She's a much more active self-agent in the bottom there. Just using her name, how a name can humanize a narrative. If you were Sandra and you got a hold of your medical records, because they are, after all, your medical records, and you read that note at the top, how would you feel?
Judged.
Judged, completely judged. And that would in turn make me pretty angry. That would make me pretty angry. I often try to learn and think about these concepts deeply as it relates to my own experience in healthcare. And I got a copy, doing great, but I had to have brain surgery a number of years ago. And I made a decision to delay that after an initial recommendation. And there was very much this sense that I was kind of refusing against medical advice to go ahead with a necessary surgery, and that I was sort of minimizing and in denial of the gravity of the situation, which was, I mean, I'm a researcher. I had about 100 pages of research. Like, it was a very informed decision, and one that I to this day don't regret. But you can imagine how that made me feel when I was kind of felt characterized in that way, you know? All right, just in the interest of time, I'm gonna go ahead because I wanna give us a very quick break, because then we have to dive in and do all of our polls on the documentation and our exercise, okay? Strengths-based language. This has concrete implications for recovery plan goals. Traditional treatment plans might say something like, patient's going to experience improvements in interpersonal boundaries and socialization. What on earth is that? Whereas, like, I want to have friends and family in my life, right? I want to get a girlfriend, whatever it might be. Okay, so direct implications for our plan documentation. So to conclude this aspect of our 4 Ps model, Vanessa is going to drop into the chat a link where you can access a nice summary tool that we developed in an online curricula called the Recovery Roadmap that just covers a lot of what I've covered in this opening section around how this looks different from a practice perspective in the process and in the relationship, okay? Then we're gonna dedicate all the rest of our time to how do you actually maintain this person-centered stance in the actual documentation, which I know is a big leap and a source of much confusion. So we're gonna make sure we answer some of those questions when we come back from a break. So without further ado, I'm going to ask 10 minutes that we reconvene promptly at the top of the hour because we do still have quite a bit of agenda to get through with our different exercises with the plan documentation, okay? So 10 minutes, feel free, videos off, mute yourselves, and we'll get right back going at 3 o'clock sharp. See you soon. I'm taking a look at the Roma assessment data. So if you can get ready to put that into the chat, that would be helpful. For those of you that are back with me, keep an eye on the chat and be ready to click on that Roma assessment data. I'm gonna go through a handful of slides before we take a look at it. But again, in the background, if you're back with me, we can go ahead and start opening that, okay? Thank you, Vanessa. All right, if you are back and you hear me, please try to put your cameras back on so I have a sense that people are with us. There we go. If you have to turn them off after, that's okay. If you need a snack. Okay, let me transition here because I want to make sure we get through the full body of the curricula, and then I'll pause to take some questions, okay? We've talked about the philosophy, we've talked about the background, we've talked about the process, okay? In my experience, what very often happens, you have philosophy, process, plan, documentation, and purpose. Those are the 4 Ps, okay? A lot of times where the quality breaks down is moving from the process to the plan. People have the values in their hearts, and sometimes they're very person-centered in their relationships. But then I go pick up the plans that they have co-created, and they say, goal number 1, medication compliance. Goal number 2, achieve and maintain clinical stability. And all that beauty of the strengths-based person-centered dialogue somehow gets crowded out, okay? And one of the reasons it gets crowded out is that people get very confused figuring out how to navigate being between this rock and a hard place up here. On the one hand, there's increasing recognition. We need to be collaborative and person-centered and strengths-based, but at the same time, many of you may have had the experience where you get chased around with auditors with red pens and they're looking for, are you meeting your billing and compliance criteria? Do you have the golden thread of medical necessity? Are you meeting the state regulations, which are often very difficult to make sense of, okay? So how do you balance the spirit of what it means to be person-centered with the rigor required in plan documentation, okay? And how do you do that without creating plans so long and so detailed that no one's gonna actually really bother to use them, okay? I have actually seen some systems that create 2 plans, one for the person and one for the funder. And you all don't have time very often to write 1 good quality plan with the individual, let alone 2. So I believe there is a way to marry these different tensions and expectations in 1 good quality plan, okay? So here's a big picture perspective. And oh, just a technical note. During the break, I skipped over a quick video I was going to share to make sure I can get through the bulk of the polls and the interactives. I'm hoping to share it at the tail end. We'll come back to it, okay? People with lived experience talking about the power of this model impacting their lives, okay? So again, hoping to end with that as our encore there. So you may notice some differences in this kind of overall logic model of documentation right out of the gate. It is organized around the goal, the person's goal, not the problem list, okay? We have a balance in the strengths and barriers. Then we ask the question, what's your first step in the right direction? And how are you going to know you're making progress? That is the short-term SMART objective. And then finally, how does everyone on this expanded person-centered team work together in support of the individual? Okay, I'm going to go through each of these in greater detail. This is just a sort of a big picture perspective. And before I go through each of those boxes, I want to highlight how this method is really a radical departure from how we traditionally do treatment plans. Traditional treatment plans get organized around the problem list, like you see on the left. You do an assessment, you have a conversation, you identify these 4 problems, and then for each one of these problems, we develop a goal around it. So if somebody has assaultive behavior, like what's your goal for your assaultive behavior? If they're struggling with their hygiene or their self-care, like what's your goal for your poor hygiene? What's your goal for your voices, right? Like you can see pretty quickly how that plan gets very distancing, feels very offensive, and it doesn't really speak to those things that are most important in the person's life, okay? In the person-centered world, those barriers may be important, but we only talk about them insofar as they get in the way of what the person says is most important to them in their lives, just like you did with your list of top 3. So a person may say, I want to get my job back so I can provide for my kids. And then we have the conversation. So is there anything that you shared with me as I've gotten to know you this last month that we've covered in the assessment? Like, what do you think's getting in the way of that? Well, I lashed out when I was feeling unsafe and anxious at work. And so I had a conflict with my coworker and I got fired, okay? I don't always put my best foot forward if I'm really depressed and not taking care of my self-care, right? And if I want to look good for interviews, then I might need some support around my self-care. Maybe I'm struggling with substance use and I called out absence so many times that I got let go from my last 3 positions, okay? So hopefully I'm trying to illustrate here is that you see how we're addressing the barriers always in the context of how is it interfering with what's important to the person. This is a really critical tool to maintain the person-centeredness of the plan and to really engage the person. Okay, so we'll come back to the goals. I want to be very clear, moving away from the left and towards the right there, okay? So what I want you to do now is we're going to use Roma for the rest of our time together. You don't have to read this tiny font on the screen. There is a link in the chat box, a document that Vanessa put in there. I want you to open it up and I'm going to give you about 5 minutes or so just to read Roma's story, because then I'm going to coach to each element and we're going to practice and have a conversation around what do we think might be the best goal for Roma's plan? What might be the best short-term objective? Okay, so go ahead and please start reading the Roma sample. And unmute and let us know if you're having technical difficulties. And Vanessa, maybe you can help with that if needed, because I'm not of any use there.
Yeah, I'm in the chat now and I'm not seeing the link.
It's a couple, scroll up just a little bit. It's from Vanessa. It's called Roma Assessment Data. It's right above your message, Denisha.
Well, I know I had to re-log on because I got kicked out. So that could be possibly why I'm not seeing the chat anymore.
No worries. I just posted it as a file again to the chat. So you should have received it as a file in the chat. And if people do not see that, please let me know and I can try to send you the link.
I'm not seeing the link either.
I do see it. It looks like most people see it. We have a couple who don't. I'm also wondering, Vanessa, if they typed their email address in the, I don't know if that would work, if their email address in the chat.
Yeah,
if you have
if they could,
file, you could fire it off.
yeah, if you could put your email address and direct it to me, so you don't want to share it with everyone, I can send it to you right now.
And we will summarize after people are done reading as well, okay? So Vanessa has helped us troubleshoot in the background. We have a couple of people who may still be waiting on the files. As you finish up reading, I will just summarize, especially for the folks that are downloading from email, a couple of the sort of key points of Roma's story, okay? So she is a loving Puerto Rican mom of 2 teenagers. She is also a survivor of multiple traumatic losses and adverse childhood experiences, which includes sexual abuse at the hands of her father and having a child as a result. Her daughter is a result of that abuse, okay? She has a long history of struggling with substance use, major depression, prominent trauma symptoms, which have also led to struggles with homelessness, legal issues. She came from Puerto Rico to the New England area and had been living with an aunt and uncle, is very close to a cousin who has been supportive throughout the years, who has temporary custody of her children after a period of incarceration. Fairly recently, she had been living with a cousin, but had been struggling with some slips that she acknowledged with her drinking, and she was having blowouts, very volatile arguments, including one pretty significant physical altercation with her daughter. The cousin at this point asked Roma to leave. Roma had been living with the cousin and her children upon being released. And she was referred to a local transitional shelter and to behavioral health services. And Roma, very highly motivated to get her kids back, to kind of get things on track, had been doing well while she was in the shelter, volunteering in the reception area, very well liked by peers at the reception area in the shelter. And she also had a lot of strengths to draw upon. In addition to the support of her cousin, she was incredibly resilient, had always been very creative and artsy, sort of found refuge in some creative activities, okay? And in addition, Roma did also live with a medical issue, hepatitis C, and had kind of been flagged along the way as refusing to see the doctors, okay? So this is sort of a snapshot of Roma's story, okay? And when you think about what a traditional treatment plan may look like, it could be very tempting to just devolve into a very problem-driven, compliance-oriented plan. She has chronic psychiatric issues. She's unable to live independently due to her co-occurring disorder. She's demonstrating poor judgment. She has to be med compliant. She has to have increased insight, better anger management. Around the substance use, she's not attending 12 steps. She minimizes the role of substances in her life. Lots of stuff in a sort of, again, more traditional problem-focused plan about, submitting to different drug tests or urine screens, complying with her probation officer, okay? Again, these things are aspects of these things that could potentially be a benefit to her in her recovery, but these are not the things that speak to her in her life and what is most important to her, okay? So she, like Mr. Gonzalez earlier, right, again, is feeling like this. These are not my goals. You put them on my plan, okay? So let's talk about how it could look differently, okay? If you have an enhanced assessment, right, in this process, your plans are only as good as the assessment that they're based on. We're not going to get into the nitty-gritty of assessment, but I think it's important to say they should be expanded in these areas. You need a lot wider and richer exploration of strengths. We got to really be thinking about cultural preferences, especially as it relates to treatment, taking into consideration what's someone's sort of stage of readiness? How ready are they to dig in? Do they want to make small changes? Do they want to make big changes? Are they trusting of the team? Or do we have some trust building that we have to do on the front end? And finally, we have to really have a more person-centered understanding of the individual before we try to co-create a plan with them. And that step of the process before you do the goals, the objectives, and the interventions is what is often referred to as the integrated summary, okay? So you may call it biopsychosocial summary, concluding narrative, conclusion, but it's like usually a written narrative that comes between the assessment data and then the plan. And I just want to really highlight the importance. In these summaries, very often what we see is people just spit back the data. They start repeating all of the facts, everything they've already said in the assessment. And the task is really different in coming up with a more person-centered understanding. We always say you have to answer the why question, right? Meaning like, if someone's struggling with something, don't just tell me again for the 10th time that they're not using their medications. Tell me what is your understanding after partnering with the person about why they don't use them, okay? Because depending on what your answer is to that question, your plan could go in very, very different directions, right? And you could miss an opportunity to really individualize the plan in a way that is much more person-centered. So I just gave you a couple of examples up here that if you are, again, sort of thinking thoughtfully in partnership with the person, maybe a supervisor, about how do you understand what's going on, only then can you offer the most appropriate intervention. If they're concerned about side effects, then maybe you gotta help them advocate with their doctor for different doses or protocols, or if they're experiencing sexual side effects and it's impacting their relationship, then maybe they would like to involve their partner in some way. Maybe someone has a cultural preference to use alternative remedies and healing solutions, okay? Do we learn more about those? Do we collaborate with somebody, right, in their faith community or their cultural community? Or maybe they're like my mom, she believes in her medications, she knows they help, but she takes so many of them, she can't even organize them anymore. So sometimes she gets confused and she misses them. So then I would be thinking about a rehabilitative strategy, like organizing by shape and size and packing in a pill box, things like that, okay? So don't underestimate the importance of that step. And let's look at how it would relate to Roma, okay? So this is just a quick snapshot of what a summary might look like for Roma. Vanessa is going to go ahead and put the Roma summary in the chat box so that you have an opportunity as we go through and Vanessa puts these documents in the chat box. By the time we're done, we're going to have a complete sample of a plan, a summary, and an assessment data package. So you'll have kind of like a resource leaving, okay? But the important thing to remember about Roma is that you can send her to every anger management group on the planet, and you can send her to every parenting group on the planet. But the truth is, these volatile arguments that she's having with her daughter, remember, her daughter is now at the exact same age that Roma was when she became pregnant with her. So as much as she loves her daughter, she is a living, breathing embodiment of her history of abuse, her traumatic abuse, okay? And if we don't start thinking about the importance of really connecting her to good trauma-informed care, all the parenting groups and anger management in the world is not going to fix that in itself, okay? That's what we mean about a deeper person-centered understanding of the individual, okay? Same kind of thing. If you were Roma, would you want to go behind closed doors with a male doctor all by yourself? Right? You would say, absolutely not, okay? So do we start thinking creatively about would her cousin go with her? Could we find her a female doctor? Is there someone on the team who might accompany her the first time? Could she ask for a nurse to always be in the room? These, again, do you see how we're coming up with very different, more personalized interventions? So we'll move on to what I call sometimes the guts of the plan, goals, objectives, interventions. But I can't emphasize enough the importance of thinking through with the individual first, how you understand things, okay? So you do have a copy of a summary for Roma that's been dropped into the chat. So now you have the assessment, you have a sample summary. Let's take a look at what the plan could look like. Okay, we're gonna do some polls for goals, objectives, and interventions after I coach, okay? So starting at the top, the person-centered plan is driven by goal statements in the person's own words, typically around things like you see on the screen, just like the things family, friends, and faith, right? That some of you put in your top 3 this afternoon. It's been a long day, right? I want to see my grandkids. I want to control my money. I want to get back to church, okay? Whatever it might be. People want to be part of the life of the community, which goes well beyond the territory of the kinds of goals that we historically see on more problem-driven treatment plans, right? This is much better in recent years, but I will still tell you, I do probably thousands of chart reviews, and I still see this with more frequency than I should. Achieve and maintain clinical stability, achieve abstinence, and take your meds, okay? So this is an opportunity to really expand the meaning of the plan for the person, okay? So I'm gonna open our first poll, and then we'll talk a little bit about goal statements, which one you think is the best, and also be thinking about why the others are not the best, okay? So I'm gonna open up a poll here, launch a poll, and ask each of you to respond to it. And please feel comfortable doing this. These are anonymous. This is just an opportunity for us to check our understanding together before we go further. Great, we're getting up there. I'm going to give you a few more seconds to respond. All right, here we go. So you should be seeing your collective responses. You all see the results? Yeah, okay. So we are off to a great start. I've sometimes gotten upwards of 90%, but you all really hit it right out of the gate, 100%. Absolutely, right? Simple life statement about what is most important to her, what's going to engage her, motivate her to do the hard work to get there. I want to be a better mother for my kids, and I want to get them back, okay? That first one, it actually is a quote, and you could hear her saying that, but why is that one maybe not the best answer? What do you think? Anybody want to volunteer why the top one you think is maybe not quite the best? Yeah, go ahead, Valerie.
It's not defined enough. Like, it doesn't tell you how to, well, first it's sort of a negative statement. It's that I don't want to do something.
Yes. Yeah. So it's a little bit of both, but the big thing I want you to notice is that second part. It's very negative. And ideally, we don't want to be about goals to be about everything we want to get rid of and things somebody doesn't want to do. It's if you're not doing that, what do you want to do and how is your life going to be better? And that would flip it in a much more positive, I want to be a good mom, okay? So the other way to think about that is you want goals to be things, not that people are trying to get rid of, but what are they moving toward in their recovery? Good. How about like better managing distress without drinking? This is the long-term overarching life goal now. Anybody have an idea about that one? That might help her get there. But is that the North Star? Is that her long-term goal? No, right? So if you were to say to Roma, so if you could handle, all the distress, how would that help you in your life if you were able to stop drinking? And she would say, I think I'd feel more in control and have a better relationship with my kids and get them back. Okay. And then, Amy, you have intermittently had your hand up, but we haven't seen you on the screen. And if you can hear us, please try to keep your phone line muted. We're going to keep manually muting you just because we're getting some audio. We would love to hear from you, but we're getting some audio interference. Okay. Roma will attend the anger management group. It might be helpful for her, but most importantly, what we're talking about at this stage of the plan is the personal life goal. It's nobody's life goal to go to an anger management group. Nobody's. That may be an important part of the plan, but we're not there yet. That's an intervention. We're going to talk about that later. Okay. So excellent. Great job, right? Everybody's, down the right trail here. Let me say a little bit about strengths and barriers, and then we'll dive into objectives. Okay. And let me know, unmute or put a question in the chat. Okay, good. I think we're good so far. Okay. So as I had said, in the person-centered world, strengths take on much more prominence in the plan. And we think about strengths very broadly, okay? They can be strengths inside the individual. They can be strengths in their family, their neighborhood, their faith community, cultural community, you name it. Anything that they can draw upon as they move toward their goals in their recovery. Okay, and I encourage people to really cast the net broad here, and to be as specific as possible. And again, I always relate a lot of this stuff back to my own life. And years ago, when I started to have my serious health issues, I knew I was going to have that big surgery. And the neurosurgeon said to me, the best thing, really the only thing you can do is be as healthy and strong as possible going into that surgery. And sure enough, I had been trying for years to get in shape. I was a couch potato mom. I had little kids. I had a busy job. Okay. But in talking with my husband, I'd always wanted to get a dog. I'm a huge animal lover. And I knew that if I had that puppy and that puppy had to walk every single day, I knew that would get me off the couch. And that was the beginning of a journey to wellness for me. That led to walking, led to running led to the gym. And I'm probably healthier now than I've ever been. And it really started by just kind of tapping into that. So again, cast the net broad here, because you would be surprised, right? The kinds of things that ultimately prove useful, okay? So I just gave you some examples here. It could be anything from spiritual direction, from a faith community. Heard lots of examples, right? Through the years, people who just love music may benefit from headphones if they're feeling distressed by voices, okay? And at the same time, of course, the focus on strengths does not mean that we completely crowd the barriers out of the plan. We have to get a clear sense of what is getting in the way and have that understanding with the person in order to be able to then brainstorm together. How can we help you overcome these things? Okay, so the questions you want to ask yourself: why can't the person achieve this goal tomorrow? Why can't they do it on their own? What's kind of getting in their way? Okay, and like all parts of the plan, soliciting the person's perspective, but also there may be things that you add to the puzzle, of course. Remember, this is sort of a blend of professional expertise as well as the wisdom of the person's lived experience. So, start with how they understand something, right? And then thinking about, listen, in work supporting other people, the way this has been described to me sometimes is like this. What do you think? Okay. So it's a blend of voice. And when you go to document it, I would encourage you to be as descriptive as possible. A lot of times in the barriers section in a plan, I see these examples on the left, which are not the best. They have anger issues, they have depressive symptoms, they have addiction. Okay, that could look completely different for every individual. So say a little bit more about what that looks like. Not just anger issues, but the person's maybe having outbursts and a lot of conflicts with their neighbors, right? So they keep getting in trouble, in their apartment complex. Maybe they're so depressed that they don't have the energy to maintain like basic household cleanliness. And maybe they're in one of your housing programs and you're worried they may not pass the housing inspection, right? Sometimes we have housing inspections, okay? Or maybe they're struggling with substance use and people are coming and going and the police keep getting called and their landlord wants to evict them. You see the difference? If you had to guess on the right, these are barriers now, what do you think that this person, what goal do you think they were working on? What goal was important to them? What's the theme there? Someone unmute or put it in the chat for me. There's a pretty clear theme there. What is it? Outburst with neighbors, can't take care of their apartment, gonna get evicted. What area was this person's goal in? Nobody's gonna be brave and help me out?
Substance use treatment?
They might need substance use treatment, but that's because they're getting motivated because they're about to get evicted from their apartment. Person wants their own home. They want to stay in their apartment. Yeah, housing, right, Elizabeth? Okay. So the reason that's important is that when you can be more descriptive, it's an opportunity to connect the dots back to the person. Like, I don't keep coming back to these things as a clinician because this is my agenda, right? And I'm, looking to harp on you about them. It's because like they are genuinely interfering with what you have told me is your most important goal on your plan, which is to be able to stay in your apartment, okay? So it's an opportunity to connect dots and keep the person engaged. Okay, people with me on this so far? Before we go, again, feel free to put questions in the chat. I'm doing a pretty good job monitoring that as well. Okay, raise your hand if you have experience writing these short-term objectives, because they're often the hardest part of the plan to write. People tell me they're so hard. So what are they and why are they important? So you have your big overarching life goal. You know the strengths a person has to draw upon to move toward that goal. You know some of the barriers that might be getting in the way. Then the next step in the plan development is what is going to be the proof that you're getting closer. How are you going to know that things are getting better in a concrete way that you can feel good about in a short amount of time? That's what the short-term objective is. I think of it, I'm still obsessed with my very old school Post-it notes, and I write things down and I cross things off the list. And even though like the overarching goal may be a long way off, that experience of crossing something off the list, I take a breath and I say, I'm getting there. I'm getting there. And objectives on the plan, well written, can play the same function for the person. They send a hopeful message that we think things can and will be better in a concrete way in a pretty short amount of time, even if the goal is longer term, okay? So they're a very critical part of the plan. They're also a very hard part of the plan to write. So many of you may be familiar with what we call the SMART criteria. There's a little bit of debate in the field about what these things stand for, but the basic gist of it, right? You want that short-term objective, also sometimes, by the way, called the short-term goal. Okay, they're called different things in different treatment planning systems. So just so we're all on the same page, short-term objective equals the short-term goal, okay? So you want it to be simple or specific, straightforward. Sometimes people say concrete and measurable, meaning at the end of the time frame, like did it happen or did it not? And if you can't agree on the answer to that, chances are it was a little too soft on the front end and it needed to be defined a little bit more, okay? Is it achievable? Meaning like, is it at the right fit? You want it to be ambitious enough that the person feels like it's meaningful, but not like such a big jump that they're not going to have a likelihood of achieving that, okay? So is it at the right fit? And is it relevant? Okay, that may be a different one that some of you may not have heard. Sometimes people will say realistic, but honestly, in all my work, doing this work in different states, I always ask the question, like, what is really the difference between achievable and realistic? And I haven't really gotten a very clear answer to that ever. And increasingly, I think the concept of relevance is more important. Sometimes we see things on recovery plans that are not so relevant to that particular individual. So let me give you an example of that. Let's say that someone is struggling with their self-care and hygiene, and they let you know, like, when I'm really not feeling well, I can't get out of bed and take a shower, right? And you have this conversation, it's in the assessment. If that person is looking to date or get back into the workforce and go on interviews, then it might be a relevant objective to help them with some of the self-care, okay? But I often use the example, let's just say you're working with a grandma, right? And she is right now, she's not in the workforce, right? Maybe she's not dating. Maybe she's staying at home and she's watching her grandkids for her daughter, right? Those grandkids honestly don't care if she showers a minimum of 3 times a week for the next 90 days. It's not relevant to her goal. Can she make me macaroni and cheese without burning the house down? Can she safely retrieve me from the bus stop at the end of each day and get me home safely? Those would be the kinds of objectives that would be really relevant to her wanting to be a good grandma and take care of the kids, okay? And then T is time frame or target date. Like, by when do you both think you want to see this thing change, okay? So here is a formula. And I see some people taking what might be notes. And Vanessa, can you just confirm, we can also get people the copies of these slides, correct?
That's correct.
Yes. Okay. So just stay with me and let's talk it through, finish our polls, because you'll get copies of all this stuff. So this is a technical formula. You can write a SMART objective without using all of these prompts. Like, question often comes up, do I have to use the as evidenced by? So let's talk a little bit about that. A formula that will help you hit the elements is, within what amount of time is a person going to have an improvement in what particular barrier that they're struggling with, as evidenced by what positive, meaningful change that they want to make in their life, okay? You can write a SMART objective without always using that as evidenced by, but since measurability is something that people often struggle with, I often recommend, especially early on as you're practicing your objectives, to use that because it will help you tighten them up, okay? So I just gave you a couple of examples. Within the next 30 days, John's going to have improved management of his panic as evidenced by riding the subway to work without getting off the train before his stop. This is a real example of somebody working in the city, is really struggling, very distressed with panic attacks. And he wanted to keep his job more than anything else. But like many people, public transit in the city would often sort of trigger. And so he would sometimes be late or miss work because he was really struggling with that. So it shows you it's addressing a relevant barrier. You know what he's hoping to change and by what date. Okay, so that's just a little bit of a formula. And then a couple other tips on objectives before our poll. I really want people to pay attention here because this is one of the biggest quality flaws where the documentation goes south and the quality gets compromised. So sometimes people do a nice job with the goal. They have a sense of the strengths, they have a sense of the barriers. And no matter what the long-term goal is, I want my kids back, I want to have a better relationship with my husband, go back to church. I go down to the short-term objective, and the objectives all say things like, Janice will attend therapy, Janice will see the doctor, Janice will meet with a job coach. And all those things are a very important part of the plan, right? But think about that. The therapist, the doctor, the job coach, they can be an important part of the plan, but they are not the short-term objective. What are those things I just mentioned? What are those things? Somebody put it in the chat if you're going to still be shy here with your microphones. Doctor, therapy, job coaching. What are those things? They're not short-term goals. They're interventions. Thank you, Criselda. I don't know if I got that right. Thank you. They're services, they're interventions, right? You can attend services faithfully your entire life, and some people have, and not get better. You have to write the objective in a way that we're checking whether or not the person is enjoying the desired change. So just to give you an example of this, years ago working with a woman who was a trauma survivor, and when she was struggling with really intense emotions over the years, she had been using self-injury to regulate and cutting to regulate really intense emotions. Okay. And she was married, and eventually her husband and she became estranged, in part because he was very overwhelmed by all of this. And so the team did a really nice job of capturing the goal that was important to her, which is, I want to repair my relationship with my husband. Okay. But then I went down to the short-term objective. And the short-term objective said, Wanda's going to attend DBT, which is dialectical behavior therapy. It's a kind of therapy if you're not familiar with it. Attending the therapy is the service. It's the intervention. The question you have to ask yourself when you go to write the short-term objective is, if all these services are actually helpful, what do you want to be able to do differently in your life, Wanda? And what Wanda wanted to be able to do differently is she wanted to have different coping skills, so she didn't have to, in a moment of real intense emotions, resort to self-injury. She wanted to cut less. She wanted to be able to have other tools in her toolbox. Okay. So the objective is not, attend therapy. Maybe she's going to use some of the mindfulness techniques to reduce her instances of self-injury to no more than 1 per week, or to none in the next 30 days. It would all depend on your conversation with Wanda. How frequently does this happen? How overwhelming is it? What do you think would be a good first step for you? Okay. And you would negotiate that with her. But I want to make sure that people see the difference. Another way this often comes up is around substance use. If someone wants to go to work and substance use has been a barrier for them, the short-term goal is not attend substance use treatment. That's the intervention. The short-term goal is some kind of measurable reduction or elimination of substance use. People can attend substance use treatment faithfully for years and still leave group and go out and they're struggling with continuing to use. Sometimes people could actually teach our groups, right? But doesn't necessarily mean they're changing their behavior. And so we really want to write the objective in a way that we're checking, is the person getting better and moving forward in a way that feels good for them? Very slippery slope. Is everyone, I want to make sure that people understand this, just because it is. And once we're aware of it, it's actually pretty easy to fix. So in consultations we do on plans, I often say, if you start writing the short-term objective and you see yourself saying will attend, like cross those words with a big X, like get them out of your vocabulary. Because the minute you start saying that, you're almost always slipping into the services section. Okay. So think about this for a minute. Vanessa's reassuring you all, you'll get these slides so we can kind of keep moving with our polls, but you are going to get all of these. These couple of slides just help you think about the A of SMART, which again is achievable. Like, how do you get just the right fit? And you can ramp it up or down depending on where the person's starting and how big of a leap they feel ready to take. So maybe Audrey wants to go back to work, but she's so severely depressed, she can't even get out of bed right now, and she's sleeping 18 hours a day. Maybe an achievable first objective is that she's going to be less isolated or have less sleep disturbance. She's getting out of bed by 10 a.m. 4 days out of 5, right? Just get your morning routine on track so you can get to interviews. You can go on the job search, okay? Down the road, if she's feeling a little better, maybe she's ready to work on her resume. Maybe she's ready to go on interviews. Maybe she gets a part-time job. Okay, so that's one way to think about the achievable. And then the other factor that plays in here, remember we said an assessment, you want to think about stage of readiness, okay? This often comes up and is related to substance use, that applies to many situations, right? If someone is really struggling and they come into services and they perhaps have been mandated to treatment and they're saying something to you like, I don't have a problem. It's not a problem. The judge sent me here. I'm going to do my time in this program and get out of here. They don't see yet the consequences of the substance use and they don't see yet the benefits of giving it up. You don't want to write an objective in that plan that's about achieving lifelong abstinence in the next 30 days. It's not achievable, okay? You want to scale it back, think about all your motivational interviewing. Like, where can we start? Like, let's just have a conversation and talk about the costs and benefits. Like, can you identify at least 2 things that this has cost you, negative effects that it's had on your recovery or your life, just so you can like tip the scales in the action stage, okay? And then maybe down the road, if someone says, yeah, I lost my car, I lost my house, I lost my wife, I need to get this under control, then maybe they're ready to reduce their use. Maybe they're ready to eliminate their use. So again, just trying to give you suggestions for how you could ramp it up or ramp it down based on your person-centered understanding with the individual of where they're at, okay? So let's open the poll on the objective. And again, I want you to read these through, think about what I just talked about, and what do you think would be the best objective? And then I think we'll get through our interventions just in time. So go ahead and vote the best SMART objective that hits all those criteria I just talked about. Remember what Roma, her big goal is, I want to be a good mom and get my kids back. She's got a lot of things getting in the way of that. What might be some proof to her that she's getting closer? All right. Either I'm a really good teacher or you all are really very skilled already. Maybe a combination of both, hopefully. Yeah, right? Like, okay, I want to visit them. I want to visit them and I want the visit to go well. I don't want to feel out of control. I don't want to be having these outbursts. Even better, maybe Roma and her daughter could identify something positive that they want to do together. That would also be a great objective, okay? Referring Roma to a community parenting group, the top one, could that be helpful for support? Sure. But that's really more of a referral. That's a service to help her. That's not her short-term objective. Demonstrating improved anger management. First of all, what does that mean exactly? You haven't really defined it, the measure, okay? Well, if she's feeling more in control, she's going to have these successful visits with her daughter, okay? And then the bottom two, again, remember those will attend mental health appointments. That's a service, so strike those words. And then the bottom one is all compliance focused. And on top of that, it's using language that I would say is less than person-centered, right? She's going to have no dirty urines. That fits with our emphasis on really trying to move away from judgmental, pathologizing language, okay? So for a bunch of reasons, the others are not the best, okay? All right, we're in the home stretch. Just finished with intervention. So we have a minute here, a couple minutes at the end for questions. Finally, we're talking about how does the whole team work together to help Roma to get there. We often see some evidence-based practices in here. That's what EVPs stand for. We want to respect individual choice as much as possible, and we want the interventions to be tailored to the individual. In addition, they do need to support what is called your quote unquote medical necessity, right? They're an opportunity to show how the professional services that you provide help a person overcome mental health, addictions, trauma issues that are interfering in their lives and causing them distress, okay? The way we encourage people to write the interventions is to think about the critical W's. Who's providing the service? Ideally by name, if possible, right? Because this is the plan is a tool of accountability, so the person knows who do they go to for what. Sometimes when you work in a team, whether it's assertive community treatment, residential, wraparound, there may be more than one person who does that, but in that case, I would suggest try to identify the role, like if it's the team nurse or the clinician, okay? What exactly are they doing? Like, what's the name of the intervention or what's the task that you're doing? When, like one time a week for the next 3 months or one time every 3 months. So the schedule and then why, and just a little phrase about what's the purpose and the intent for this particular individual, okay? In this case, Roma's story, okay? So in here, I'm just giving you examples of interventions that hit all of these W's, right? So maybe the psychiatrist will provide medication management once a month for 30 minutes to adjust medications to reduce her symptoms and her tendency to isolate and be uncomfortable in social situations. Who, what, when, why, okay? And just remember, again, translating principle to practice, we want to expand the team. And if you're working with someone who loves to read and they're computer savvy, look at the bottom left corner there. Maybe Elaine is going to read web-based stories at night of people with lived experience of depression to give her hope in her own depression and her recovery, right? That would be a way to tap into her strengths. And on the right side, say someone wants to get back to church, and maybe you are helping them overcome symptoms that are getting in the way of that, but maybe she just needs a ride. So could Hilda's priest, Father Cronin, arrange a ride to and from Sunday services? And always thinking about tapping those involved natural supports before we step in with professional supports, okay? So last poll here, I'm gonna open up the intervention poll. And again, get your thoughts on what do you think is the best intervention? Hitting the who, what, when, and why for Roma. All right, I'm going to end my poll here. We're having attrition as we approach the top of the hour, I've noticed. Again, we've got the superstars who are remaining with us, it appears, okay? Big theme and unmet need in Roma's story that's impacting her relationship with her daughter, especially right now, as she's turned 14, is the need for trauma-informed individual therapy, okay? Each of the other components is missing one of the key elements. This clearly has the who, the what, the when, and the why, and it's very personalized to Roma's story, okay? So I'm going to leave the time we have left for some questions, but what I'm going to show you is just to let you know, we are giving you a copy of a sample of a Roma plan that we partially built today together. And that gives you, I think, 3 different areas, 3 different objectives she might be working on with a nice rich set of services and natural supports. My caution about samples is that there's no one right way to do this. It could come together in different ways depending on what Roma herself says, what she's ready, willing, and able to tackle, how much, when, how soon. So again, I'm not suggesting that this is the only way to do it. It takes the partnership with the individual, okay? So you will, Vanessa, can you please drop the Roma plan link into the chat box so that you all have access to this as well. And you will see that it follows a lot of the good ideas that you came up with in the polls, right? So very clearly, she wants to be a good mom for her kids, and she wants to feel more in control and have those visits with her daughter where they can share positive experiences together, and she's not feeling that kind of loss of control, okay? And you will see that we try to activate Roma and her cousin in this, right? Maybe Roma's coming up with a list of arts-related activities that she and her daughter could do together on those visits, right? Because remember, what is one of Roma's strengths? Creativity and the arts have been a source of refuge for her. So that's a nice example of a strengths-based strategy, okay? So you have a sample of the Roma plan. You will hopefully see how that plan can both honor the person and satisfy the chart. And, again, both incorporate what is most important to the person while also helping you feel like You're still attending to your responsibilities professionally about some of the things that might be important for them from a health perspective. And achieving that balance helps you, again, to stay true to what's important to the person, while at the same time, make sure that you are able to maintain what we call that golden thread of medical necessity, okay? So I'm ever the optimist that we can marry these things in one good quality plan. And I hope the time we've spent together today gives you some ideas about how to do that, some tools. To summarize, in the chat box, as we've gone, you have a recovery roadmap tip sheet, summarizes the process of PCRP. Vanessa's dropping in the chat a summary sheet that summarizes the tips I just went through in the documentation. And you have a complete set of the Roma materials, an assessment, a summary, and a plan. So we did it. This is a systems change. You can't do it alone as individual practitioners. This is a whole other presentation, but I just want to acknowledge this involves policies, procedures, electronic health records. Change has to happen at all levels, okay? So 5 minutes for questions. We've taken some and had a little bit of chat as we've gone along the way. But questions, your thoughts, anything I did not cover that you'd like me to go back to. And again, feel free to unmute and jump in. I'm glad it was helpful, Cassandra. Is this how you?
Janice,
Yeah,
it's Amy Ford. I mean, this is wonderful. It's just a lot to take in.
Yeah.
And I'm certainly not feeling like I totally get the nuts and bolts of what you're presenting to us. I think it's just gonna take me time, or I almost feel like I'd have to go through this again for a second time. I'm a little confused about the writing of the documentation, the actual writing of the notes, and how that would work with an electronic record where you don't have as much flexibility in. There's that piece of it. And how are you, like, I'm of course thinking about this from the lens of how am I going to teach my students this? You know, I teach a case management class, and I've always used a strengths-based approach, but a lot of what I teach them is sort of the basics and the things that you talked about in the beginning, like I'm teaching them sort of the traditional, and I've been trying to get away from that. I haven't found a particularly good textbook in which to do that. Most of the textbooks are fairly traditional in their approach.
Well, a couple of things, just to acknowledge one thing that I think you said, which I was just saying at the end. We don't want to teach the lowest common denominator, right? Meaning that this is the vision of how there is growing consensus. This is how we should do it, right? However, electronic health records are still very traditionally driven, often by pathology and diagnosis. I don't know if it's possible. And this is what I was saying. It also involves systems change. So the systems that are most successful in this also make sure that they hand to practitioners a workable electronic health record and template that allows them to actualize these skills and this method in practice. We actually wrote a paper about the promise and pitfalls of electronic health record design, what to do and what not to do. I'll talk to Vanessa about potentially having that posted as a resource along with the other slides. And just don't expect this to be fully comfortable yet, Amy. We covered a lot of territory. This is a very different method of documenting for a lot of people. My hope is that the resources we dropped in the chat, they'll sort of, take some time to digest them. And again, just hope those are helpful for sure. Somebody asked a question in the chat. Can you, when the materials are posted, can you use them to help train our staff? Vanessa, maybe you could correct me if I'm wrong. I'm relatively new to the MHTTC 6 months ago or so, but we are a dissemination center. And we are trying to disseminate promising and evidence-based practices. So yes, we want you to have resources. Please feel free to use them. That's why we dropped them in the chat. JC is making a comment regarding kind of the interface with criminal justice and parole and probation, that you do support around addiction. These tactics are great, can help us implement new wording. It is so great to have you. It's nice to hear about your background. It's, again, speaks to the importance of some of the kind of cross-system work in this. I'm glad it was helpful. All right, let me scroll. Goals are often the hardest things to think through. I would agree with that. And not all people can come up with them on their own, right? Meaning that even given the invitation to follow their lead, they might struggle, they might be feeling demoralized, they might have lost hope. So it's really a partnership. I would say, go back to your strengths-based interviewing and assessment and try to be creative about that. My favorite question around goals, if someone's stuck, if you could plan a perfect day, tell me what you'd be doing and who would you be spending your time with? And it's amazing to me how that kind of question sometimes unlocks a spark. All right. Oh, I have to say, technically, there is a link in the chat. This is very important. We collect evaluation data on these webinars. It is important to our funder, and we genuinely look at the feedback and we try to enhance our webinars moving forward. So if you could take a moment before we close to click on the link so that you could do a very short survey for us, that would be great. Stacy is talking about the difficulties interfacing with auditors. They're looking for outcome-based goals. Getting Roma's kids back is a good outcome for her. Oh, sorry, I scrolled away here. Yeah, but being a better mother isn't, right? Meaning like just sort of we got the outcomes based, we have to be concrete about what is it that we hope this person's, where are they going toward long-term goal and what's the concrete change we can see in the interim and the short-term goals. What I will just say, two things I will say there. First of all, again, this requires collaboration around administration, policy procedures, electronic health record design, also collaboration. I do a lot of work with funders, managed care organizations, really, again, trying to align auditing with this method of documentation. Okay, so that is also very critical. I will tell you, for the systems I've worked intensively with, who have gone through a lot of skills training and train the trainer, typically speaking, when they have quote unquote an audit or a joint commission review or a CARF accreditation review, typically the logic in the individualization of their plans is much stronger and they actually do better in audits. So this idea that we're going to compromise the quality, in my experience, typically is not founded. Acknowledging, of course, that there are differences across auditors, but I really do believe that this method of partnering with people and creating the plans, it does not need to compromise the necessary rigor that you need in your documentation. We can do that and still honor the person, which is the most important goal, okay? All right, I think I am 2 minutes over. I think I've gotten to the questions in the chat. Yes, Stacy, what would a better mother look like for her? Look at the Roma example, and in particular, look at some of the behavior change that you would see in those short-term objectives. They're very concrete. You get a lot of measurable behavior change that would help her move toward that. So I think that will help you. All right, I am going to respect your time and let you all go. Thank you for joining me. Thank you for doing the polls, the exercises. I hope you found it useful. Please do check out the MHTTC and our resources. And again, I hope you found it helpful. Take care, everyone. Good luck.
All right, thank you. Goodbye, everybody.